Good morning, everybody. Oh, you're so polite. So today we're going to talk about a topic which is somehow overdue at this conference, which is that one of the Tethered Cord. This speech is a companion to the presentation done by Dr. Oro yesterday. Some lingo, some basic terminology for the specific of this presentation. The Tethered Cord, we define it as the pathologic mechanism pulling the spinal cord from below. The Tethered Cord syndrome is the clinical counterpart of the effects of the Tethered Cord mechanism. The tight phylum terminale is one of the mechanisms of the Tethered Cord. Dr. Oro listed them all yesterday. And the section of the phylum terminale is the surgery that can be done in order to address the tight phylum terminale. Some warnings, some small print. The occult cord tethering so far is a highly controversial subject in neurosurgery. The controversy is not about its existence, but when to diagnose it and when to operate on it. With this presentation, we are not saying that the Tethered Cord is the cause of all tonsillar herniations and or the Chiari cases. Some scientists, some people in the field said that they're a minority. We do not espouse that cause. We are not saying either that the Tethered Cord is a cofactor, not a cause, but a cofactor in all similar cases. We're not saying either that all these results can be extrapolated for every case of occult cord tethering, because as we're going to see later, the pathologic mechanisms and the anatomical findings we found are reflective that one of a very narrow subset of patients with occult cord tethering. And we're not saying either that our conclusions can be applied to all the people with tonsillar herniation or Chiari malformation. What is this? This is the Rosetta Stone. It's at the British Museum, and it allowed about, it was 1805, allowed the Egyptologists to have an insight about what the hieroglyphics were about. And nobody could have any rough idea about what they're meaning, but then finally they found this stone, and this stone in the top third there are hieroglyphics, the middle there is Greek, the bottom there is a sort of a Proto-Arabic, and there was just a standard, internal bureaucratic document. It was in 3 languages just for easy reference. The equivalent of when you go in the touristy place, do not throw objects out of the window, written in English, French, and Spanish. And this was the first time that the Egyptologists could understand what was written. Now, our Rosetta Stone was a patient that we met in 2005. As a matter of fact, we met her before, we treated her before. She had a former diagnosis of Chiari and Ehlers-Danlos syndrome, but she was not doing that great after whatever we threw at her. She was the mother of 3 kids with Tethered Cord who were operated on by somebody else. And she had a bunch of different symptoms which were going in the upper half of the body, the lower half of the body, but mostly the urodynamics were showing that she was having a neurogenic bladder, which means the bladder did not work well because of spinal cord reasons, of unknown origin. Nobody could figure out where it was coming from. Neuroradiologically, there were some findings, but we'd screened her before for the regular Tethered Cord, and we didn't find anything. So we found a small little 5S1 disc that was nothing to write home about it. The EMG was negative. Then we started putting our hands on her. Started to figure out what's going on. Let's try to see. Let's throw some stimulation test. So we saw that all her symptoms were worsening with pulling the head up or pulling the legs down, and also by heel walking, which is a maneuver which increases, we realized afterwards, the tension on the phylum terminale. She was better while toe walking, and we noticed she was better after the surgery. Why did we decide to do the surgery? The first thing is that we had enough reason to believe that she had occult cord tethering independently. But then we were curious to see how this, especially in the face of the stimulation test, was going to impact the problems above the waist. And they did. So at that point, from that point on, we started raising our awareness about occult cord tethering in patients with Chiari. You have to make a diagnosis since the conus with people with occult cord tenderness is in a perfectly normal position. What do? You do a raffle and you say, okay, the people with the even numbers get the surgery, the others don't. So you try to go through a diagnostic process, but that's one of the centers of the controversy, since the diagnostic tools for now are not very sharp for this diagnosis. There is a lot of discrepancy among results and interpretations. Now we adopted what everybody does, plus we threw also another ingredient, which are the morphometrics I mentioned last year. Morphometrics is a way to break down the anatomical information of the MRI in objective dimensions, distances, angles, volumes, which have defined age-specific normal values. So, if you know that something is between 170 and 180 and the guy has 162, you know that is small. Dr. Nishikawa is the leading world expert in morphometrics. We're lucky enough that he works with us, so made the entire process easy. And the normal morphometric sheet contains about 40 parameters. Just a few parameters are going to be pertinent to this presentation. We run morphometrics. Usually we're doing it just for research papers on 10, 12 patients. Now we do it routinely on any patient coming through the door. What did we find in people with classical tethered cord and occult cord tethering? Similar results. The brainstem is longer than normal. Part of the brainstem is herniated in the cervical canal by a few millimeters, not by a foot and a half, but enough. And that kind of resonates with what was discussed yesterday in the terms of Chiari 1.5. The foramen magnum, which is the hole at the base of the skull, is not smaller than normal, like in people with Chiari, but is larger than normal. The cerebellar tonsils are minimally herniated in most of the cases, which means just a little bit, 2, 3, 4 millimeters. And the posterior fossa has normal volume in most of the cases, instead of the small posterior fossa, which is typical of Chiari. These are some of the parameters of the morphometrics in action. I'm not going to bother you with that, but this just reflects what I just described in the former slide. So from that point on, we started looking backwards and forward in our patients. So about 3,000 patients were seen between January 2002 and 2007. Most of them had Chiari 1 malformation with all the classic parameters, and about 300 had low-lying cerebellar tonsils. So the people that would be described as Chiari 0. You're not herniated enough to make it to the classic standard threshold of Chiari 1. 46% of them had former failed Chiari surgery, which means they had the Chiari surgery. The surgery did not result in a complication, but the results, clinical results, were short of the expectation. More women than men, and the age range went from very young to very old. So everybody was, since 1995, like everybody in this room among my colleagues, every time there is a patient with Chiari, we always screen for tethered cord, the classical form. So we're screening for patient for classical tethered cord since 1995. But if you have occult cord tethering, at that point you score negative on that test, and you keep going, assuming that there is nothing wrong from that side. So we reevaluated some of the patients, and we evaluated with this new tool all the new patients coming in. Out of these 3,000 patients over 5 years, 590 scored positive for tethered cord. Obviously, 94% of them had the occult variant. The tethered cord was diagnosed in 14% of the Chiari patients, but in a much higher percentage of the people with minimal tonsil herniation, the Chiari zeros. 318 out of these 590 patients diagnosed with tethered cord went on to surgery. So there were 74 children and 244 adults, and many of these adults had delayed presentations of their symptoms. 153 of these 318 patients who went on for surgery had the former failed Chiari surgery. 63% of these 153 had more than one surgery because they had the posterior fossa revision, cranioplasty, a VP shunt, and still they were not doing that great. 63% of these patients had also a radiological evidence of cerebellar ptosis, which means that the cerebellum comes down along with the tonsils, persistent tonsil herniation despite a former operation, an impaction of the foramen magnum, which means that the bulk of inferior part of the cerebellum and the tonsils are plugging the outlet, even if it's been surgically enhanced at the time of the decompression. This is an example of a patient with after a decompression. We saw him something like a few months later, and it was with the picture on the left. The tonsils were still herniated, and the cerebellum was coming down. Then we saw him 6 months later, and the cerebellum was even further down, and the tonsils were even further down. We saw that 1 patient out of 6 out of this tethered cord had 1 or more family members with already diagnosed tethered cord. Most of them were children. In most of the cases, the trait had been transmitted through the maternal side, hence the prevalence of women over men. And among the patients who had the surgery, we had 1 set of twins, several brothers and sisters, several mothers and so on, mother and daughter, but also the peculiarity of having a grandmother, mother's son. Morphometrics applied preoperatively. We found out that the pure form of Chiari 1 malformation, as expected, as described in literature, we selected them out, had a small posterior fossa and a small foramen magnum. This is what squeezes the tonsils out. But when we reanalyzed with the morphometrics the people with the tethered cord, we found something different. We found that they had the normal posterior fossa volume and a large foramen magnum. Measuring made the difference, because eyeballing, we're saying, it looks normal-ish or a little bit small. Measuring gives you a number, and the number doesn't lie. And either it is in the range of normal, or it is above or below, and at that point there is no potato-potato effect of 2 independent eyes looking at the same picture. The tethered cord patients had also elongated and downwardly displaced, which means that part of the brainstem had migrated in the neck, brainstems, respectively by an average of 8.3 millimeters and 4.6. So the brainstems were longer by almost a centimeter, and they were displaced down in the cervical canal by an average of almost half a centimeter. Intraoperatively, what did we find? We found that the phylum terminale, instead of being central, was positioned dorsally, so all the way in the back of the dura, in a kind of a mid-sagittal position, and against the dura. And by doing that, it was since it was under tension, was wearing out the dura and was creating a track mark so deep that you could see the nerve roots and the phylum through it. The dura usually is pretty thick. In most of the cases, the phylum was not thicker than normal, but was thinner than normal. Normality is between 1 and 1.5. These guys were running between 0.7 and 0.8 in average, with bottoms of 0.4 in some occasions. That we use the color Doppler. We measured the cerebrospinal fluid flow originally. We found out it was very low. It was as low as the people with Chiari 1 malformation when we measured the flow at the foramen magnum before we decompress, and with an average of 0.7 millimeter. In our experience, we call it normal-ish when it is about 3.5 centimeters per second. Sorry, there is a typo. That was 0.7 centimeters per second of average. Intraoperative finding. After cutting the phylum terminale, we found out that the cut stumps of the phyla, which were very thin and taut under tension, they retracted by an average of 41 millimeters, which are 4 centimeters, like 1.5 inches. These guys were behaving like stretched rubber bands. In a few cases, we found a classical thick phylum that is described in literature, and these guys were kind of a thick, lazy rope. You cut them, they were retracting by a few millimeters, like 3 or 4. The cerebrospinal fluid flow after cutting the phylum was increasing from an average of 0.7 to 3.7 centimeters per second. Big difference. Top part of the picture, you see the phylum through a closed dura and the wear mark that I was telling you. So the parts which are pink is dura which is intact. The part which is whitish and transparent, and it's not supposed to be like that, is the part which has been worn out by the phylum under tension. The middle row picture shows you on the left, the picture number B, the position of the phylum, which is all the way on top and in the middle. And the bottom row on the left and on the right, respectively, they flow at the beginning of the case and at the end of the case. You know, it doesn't take an engineer or a scientist to understand that bigger peaks means more stuff going on. Post-surgical facts. 318 patients underwent section of the falum terminale. The follow-up after the surgery averaged 16 months. 2 pediatric patients required a redo surgery. Redo surgery for tethered cord is quite a common event for the traditional classical tethered cord, but here we're having a rubber band which snaps in opposite direction and separates quite a while, so it's intuitive that the retethering process is going to be more rare. Both of these patients had the former LP shunt, so we got smarter. We went in, and instead of just ligating the shunt, we actually removed the shunt because this was creating a secondary area of tethering other than the falum. The complications were a few because this is a low complication rate operation. We had 3 wound infections, 2 leaks, 1 episode of spinal instability which required instrumentation, and 1 epidural hematoma in a patient with a coagulopathy. Post-surgical outcome. 69 of the 74 children improved, 203 of the 244 adults improved. We had unchanged results in 5 children and 39 adults, and 2 adults were worse off after the surgery rather than before. The best clinical outcomes, we found them in children. The best clinical outcomes in the sense complete resolution or dramatic improvement. Terminal thoracic syringomyelia, a condition which has been defined over the years as hydromyelia or a congenital dilation of the central canal. That usually has been described as something congenital, is not related to any cause, it's not really a syrinx, was resolved or became smaller in 20 or 23 children in 35 out of 54 adult patients, raising the suspicion that probably the tethered cord was the cause or one of the cofactors in maintaining that syringomyelia in that location. Thoracolumbar scoliosis improved in 16 out of 24 children, 11 out of 47 adults. In 187 patients with documented neurogenic bladder, the urodynamic abnormalities resolved or improved in 93% of the children and 84% of the adults, with different degrees of intensity, and with the children being the beneficiaries or the most dramatic results. The complete resolution of urodynamic dysfunction was greater in children than in adults. Postoperative morphometrics. So 3 to 6 months later, we get another set of MRI, see the patient in the office, we hear that they're going, and we remeasure the morphometrics. We found out that the conus had moved upwards an average of 5.1 millimeters, more in children. The brainstem shortened by 3.9 millimeters. The herniation of the brainstem inside the cervical canal went up by 3.3. The cerebellar tonsils across the board moved up an average of 3.8 millimeters with points with some records of 6 and 6.5 millimeters. My son actually had a 6 millimeter reduction with tonsil herniation. The cerebellum as a whole, you remember the cerebellar prolapse, moved up an average of 4.7 millimeters, raising the suspicion that probably the tethered cord can be a cofactor in the production of cerebellar prolapse. As a consequence of this section of the falum terminale, we witnessed an overall migration upwards of the brainstem and inferior part of the cerebellum, and this change was associated with a reduction of the impaction at the outlet of the foramen magnum. And once you unplug that, many other things will follow, and this logical consequence that as a consequence of this upward migration, we found a reduction of some cervicothoracic syringomyelia cavities in 15 cases, a reduction in size of massive head-to-toe syringomyelia cavities, hollow core syrinx in 6 cases, and improvement of Chiari-related symptoms in many patients. The numbers are there, including ADHD. This is a syrinx on the left before the section of the falum terminale, and then reduced to less than half of the size after the section of the falum terminale. No need to shunt over here. So what are our observations? First of all, our observations, our theories, our conclusions are still in evolution. We're still digging deep in all these Paolo patients, trying to understand. And the more we go ahead, the more we see a picture which is more complicated than we would like to simplify. So in a subset of patients with tonsil herniation, a tethered cord can be the cause or the cofactor of the tonsil herniation itself. The tethered cord, especially in the occult variant, which is easy to miss, is more frequently a factor if the tonsil herniation is minimal, if the posterior fossa volume is normal, and the foramen magnum is large. In this subset of patients, occult tethered cord is more frequent than the classical counterpart. I told you more than 90%. Occult cord tethering is quite common in cases of failed Chiari 1 surgery and can be the reason behind it. The cerebellar prolapse, the persistent tonsil herniation, the scoliosis, and the distal syringomyelia cavities are frequently found in tethered cord patients. So again, this should ring an alarm in the mind of the physician. We also found that there is an anatomical continuum. There was a guy who was saying, natura non facit saltus, which is Latin for Mother Nature doesn't make a box here and a box here. There is a spectrum in between. We make the boxes. We make the boundaries between diseases and subtypes of diseases. So there is a continuum between the true Chiari with small posterior fossa, big tonsil herniation associated with tethered cord on one side, and the cases with normal posterior fossa and minimal tonsil herniation, Chiari 0 on the other side when it's associated with tethered cord. We also found out, since we screen patient for EDS, again, you do not find EDS, you don't find occult cord tethering unless you look for it. So we did Peyton scores, all the classic connective tissue disorder scoring that we do in association with NIH, and we found out that patients with EDS have an incidence of occult cord tethering, which is 7 times higher. Now go back to the thick phylum, big rope, or thin, overstretched rubber band. The falum terminale is made of connective tissue. So if the connective tissue is defected and overstretchable, and you can do like this with your skin and bring it to the next room, you understand that the thick falum terminale that is like that at the beginning of life, if it is made of poor cement, is going to overstretch and become very, very thin and wider. So in terms of why it becomes an occult cord tethering or classical cord tethering, why these patients do not have a conus which is below L2-3. Have you ever tried to pull a car with a rope? Yeah, you can do it. But if you try to move the car in neutral with a rubber band, you ain't gonna move it. So conclusions, keep the tethered cord in mind, especially in its occult form, when evaluating patients with tonsil herniation, especially with all those kind of red flags that I listed before. More experience, we refine the diagnostic thresholds and the surgical indications in the future. We are refining ourselves as the months go. We had several discussions, very animated over the course of the last, since 2005, because we were understanding that there was this problem, but the point is, where do you draw the line in the sand? When do you call this patient, okay, this patient has tethered cord, and when do you draw the line in the sand and you say, okay, this patient has tethered cord and we have to do the surgery, or we have to keep the surgery in the back of our mind. All these things, only time will tell, and time with more and more studies, more and more experience, and but again, this is not going to come up if people are not going to go and look for it, or they're not going to keep this in the back of the mind. Thanks a lot.